Good day, folks. This is Dr. Arvind Canchi, a nephrologist based in Bangalore and the chair of the social media team of the Indian Society of Nephrology. We come to you with yet another episode of Kidney Conversations. This is a podcast that is available on Spotify as well as Amazon Music. So do tune into this podcast when you're in your car traveling long distances, as you would in Bangalore at least. I'm not so sure about Thiruvananthapuram, where my guest hails from. Dr. Satish Balan is a nephrologist based in Thiruvananthapuram or Trivandrum, as we'd call it. He's a consultant nephrologist at the Kerala Institute of Medical Sciences in Trivandrum. And I'm going to hand over to him to introduce himself. How are you doing, Satish?
Yeah, good evening, Dr. Arvind. I'm fine. I'm absolutely fine. So I'm just to introduce myself. My name is Dr. Satish Balan. As Dr. Arvind has already informed you, I've been a senior consultant nephrologist at KIMS Health. I joined KIMS Health. It was called KIMS earlier, Kerala Institute of Medical Sciences. Now it's called KIMS Health. And I joined the hospital in 2002, prior to which I was a staff of the Trivandrum Government Medical College. But since 2002, I've been here and I've set up the department and the dialysis program and the transplant and other things, but have maintained a very strong connection with academics throughout. And I'm extremely interested in teaching, which is one of my passions. So I'm just so happy to be here today on this program and to share my views about genetics and nephrology.
So, as Dr. Satish Balan said, this Kidney Conversations podcast is about genetics in clinical nephrology. And this is a subject that, not many of us have looked at in too much detail during our post graduation. We haven't been too alert to the fact that genetic studies are needed in certain situations. For example, in cystic kidney disease, in CKDU, in, let us say, nephrotic syndrome that is resistant to steroid. And these are some of the clinical scenarios that I know about. There are probably many more such clinical scenarios that Dr. Satish will tell us about. So, what do you think, Dr. Satish? What are those clinical case scenarios, let us say, in children, if you want to attack that area, or more often as adult nephrologists, we are looking at adults. What are those clinical case scenarios that you think of that, we should pursue genetic studies in such case scenarios? What is your call on this?
Yeah. In general, you see, there are a lot of indications where we can do genetic tests, but I would put it as some of these. One is where you have a family history. Suppose the patient has a family history of kidney disease. That would be somewhere where you can do a genetic study and see if there is a genetic disorder. Of course, like you already said, cystic kidney diseases, and definitely diseases which have a syndromic presentation. They have extrarenal features, which all suggest that it may be a genetic disorder. That is where it can do it. The next thing is undiagnosed chronic kidney disease, especially if you're going for a transplant, you're not sure what it is, and you don't know that after transplant, this is going to bite back at you. So that may be one situation where you want to do a genetic test with the disease is not clear. This is especially in younger people where it will be a problem if it is a genetic disease which can occur on the transplant, like a atypical HUS or something like that. So these are situations where we would be doing genetic study. Of course, there are a large number of clinical situations, like you already said. One is FSGS, then the tubular disorders, where you know that this can be a genetic component to it. And of course, if in certain populations like African Americans, where you expect a disease like FSGS, you know that the APOL1 gene can be implicated there, especially when you're going for a transplant. So there are a lot of situations, and the best part about this is that the number of indications are keeping on increasing as we speak.
Right. Now, these genetic testing that people do in the labs, what exactly does this entail? I've heard of terms that I really don't know much about. I've heard about whole exome sequencing. I've heard about targeted next generation sequencing. I've heard about Sanger sequencing, but it doesn't, sit in my mind and say, oh, this is what we need to apply to this particular case scenario. How do you look at what to apply to given case scenarios if you come across? How do you inform the nephrologist on what exactly to do?
Yeah. So basically, there are two types of terminologies that you're seeing. One is the type of test that you're doing. The second is the what genes, what you're looking for in a test. What I'm talking is the first is the type of test. By what I mean the methodology that you're doing test, and second is what you're looking for in the test. So methodology, if you look at the earliest one was the Sanger sequence, for which Sanger won, Frederick Sanger, he won a Nobel Prize for that. And that was the basic fundamental genetic test which was done for years and the whole genome project. I mean, the human genome project was based on this Sanger sequencing, and the entire human genome sequenced based on Sanger sequence. But once the entire genome was known, then new technologies have come out, and that is called. Then the latest technology is called NGS, next generation sequencing. So Sanger sequence, actually what it does is just you take a small bit of DNA, say about 200 to 500 base pairs, and you can accurately identify each and every base in that pair by using this Sanger sequence. But this is a laborious process. Imagine there are millions and billions of strands of DNA. So if you do that, it took teams of researchers 20 years to get to the entire human genome using Sanger sequence. That's why you need faster tests. And NGS is the fastest test available. It's a massively parallel sequencing. So what you're doing in one Sanger, you're doing thousands or tens of thousands or millions in parallelly at the same time. So you're able to get to the result faster. That's NGS. So this is basically the methodology behind the test. Now, when we order it, we are not really bothered about the methodology. We are looking at what we are trying to look at. Say, if you don't know what the syndrome is, you have a clinical disease, you don't know what it is, then you do a whole exome sequencing. That is, you do exome is actually, as everybody knows, exome is the part of the gene that is transcribed directly and into the mRNA and becomes a protein. Whereas the intron is the untranscribed or the bit that is not expressed in the gene. The expressed portion of the exons, that's why the EX comes into it.
Right.
So the whole exome is just you're taking all the exons in the genome, and that is being explored to see whether any of them has a particular variant that may be causing the disease that you are trying to investigate. So that is when you don't know what it is. Suppose you have say you have a cystic disease. You know that this is a polycystic kidney disease, so you know there is a very limited number of genes in causes. So you can use a targeted exome panel. So this will only investigate the exomes which are known to the exons, not the exome, the exons which are known to cause polycystic kidney disease. And that will be a targeted panel. So a targeted panel is done when you know what you're looking at, you know what syndrome you're looking at. And the whole exome is done when you really don't know what syndrome you're looking at. It's a much more diffuse entity, like an undiagnosed CKD going for a transplant, where you don't know what exactly could be a large number of disorders. So that's where you have a whole exome, a targeted exome. And then you have another test for this NGS text. All these whole exome or targeted exome are using this technology called NGS, which I talked about. Now, NGS, the problem is it is good at detecting single genes in small groups of genes. But when there is a large deletion or duplication, it just bypasses that. So you will just completely miss it. So that's why you need another test for doing a deletion duplication analysis, or what is known as a copy number variant. The other one is called a single nucleotide variant, where you're looking at this thing. And this here, we need a copy number variant, that is deletions and duplications. Another test, one of the common tests is done is a multiplex ligand dependent probe amplification assay, or what is known as an MLPA. And that is one of the tests which is being done. So these are common tests that we do, and we have to know which situations we do it in. So if you don't know what the syndrome is, do a whole exome. If you know approximately what the syndrome is, you can do a targeted exome towards that particular panel. And if you think that your particular genetic condition has deletions, duplications, which are very common as a cause of this particular syndrome, then you do a MLPA.
Right, excellent. At least I learned something today, so I will apply this, in my patients when I come across. Now let's tackle a case scenario here. We have a 35-year-old woman with no past medical history presented to my clinic, say for evaluation of proteinuria, 4.9 grams of nephrotic range proteinuria with a serum creatinine of 1.3 and the albumin of 3.6, mild edema. So in view of the nephrotic range proteinuria, we did a biopsy. The biopsy shows FSGS, NOS, no other significance. No improvement in proteinuria with a good course of steroids at 1 milligram per kg body weight per day. And this lack of response to steroid in FSGS, does that prompt you to say, let's go for genetic testing? For example, I would then go on to decide on whether I would want to use CNI, rituximab, and so on. But should I pause here and say, wait, this hasn't responded to steroid? Should I look at genetic testing? What's your take on this?
Yes. So the point here is about a steroid-resistant nephrotic range proteinuria or nephrotic syndrome in an adult. So in a child, if you're doing a steroid resistant thing, the genetic yield is about 60% or so. Whereas an adult, if you're doing it, it will be about 40% or so. But one of the things you have to rule out here is whether it's a secondary FSGS. So whether you have some other, like an
Right.
obesity-related glomerulopathy or something which is causing a secondary. So if you are fairly confident it's not a second, then I think the next thing to do is immediately go for the targeted exome panel. So you have a large number of genes. At least I think at the last count there are some 40 or 50 genes at least which are involved in the genotype of primary or a genetic FSGS. So this would be a good place to do a targeted exome sequencing for this particular genes. Now, one of the because you're fairly clear that this is a syndrome that you understand, it's an FSGS. And FSGS is due to a limited number of proteins which are expressing on the podocyte.
So you were talking about what to use for FSGS whole exome and targeted whole exome.
Yeah.
So in such patients, let us say minimal change and FSGS who are not responding to steroids, obviously we're talking about adults here. So would you want the clinician or the nephrologist to say, don't go on to rituximab or CNI or other drugs. Maybe wait, send the clinical, genetic testing first, and then decide based on that. Would you say that? Because if a genetic test comes up positive or shows something of concern, it means that immunosuppression is not going to work in those patients.
Yes, precisely. I think that's very important. There are some reasons why you should be doing genetic tests in these patients. It is not just out of academic interest. So one of the things is that it can prevent unnecessary immunosuppression, as you already said. So what we would do here is that if the patient doesn't have a frank nephrotic, not much of edema, that's one of the troublesome problems is when they have edema and you want to try and get it, very difficult to get rid of the edema in a very bad nephrotic. But if that is not a big issue, then you can always start anti-proteinuric measures like RASI and SGLT2 and etc. And then you can do a genetic test. The results will usually be available in 3 weeks or so. And you can wait for that time to plan your immunosuppression. If the genetics becomes negative, that really does not mean that it's not a genetic disorder. It just means that whatever genes we have covered, whatever genes we know cause FSGS so far, those are not the causes. It may be some unknown gene or even an unknown variant in a known gene. Both these can be present. In fact, it may be good to go back to your genetic study after 1 or 2 years and again read the whole thing. You can ask the geneticist to go back and look into it and see whether something has come up. Because in the next 2 years, probably you'll have new information which will be valuable in providing a better diagnosis of these patients. So that's one of the things that you do a genetic test once, that is enough. Because later on you can go back and do it. You can screen that again and see because the data is there already.
Right. So if a patient with, let us say, resistant FSGS, resistant to steroids, you do genetic testing, what sort of a yield is there? Do you get a positivity in about 20% of patients, in 40%? What is the yield of that test?
Yeah. So it depends on what we are trying to look at. Say FSGS, like I already said, adult FSGS, the yield will be around 40% or so. The yield is 40% doesn't mean that only 40% are genetic. It means that only 40%, like I said earlier, 40% of known genetic disorders. In fact, if you had gone 10 years back, the same group would have had 20% yield. Now that's 40%. So it's immediately gone up. So even they had studies on CKD, undiagnosed CKD in 2010, 2015, that period. You'd have seen that the yield of a positive test was about 20% or so. Whereas now it is about 35 or 40% in those patients because we know more genes, they are better at finding these diagnoses. And if you look at another syndrome like say ADPKD, the yield is going to be much better. It's at least 70 to 80%. You're going to get a diagnosis. There are some which still, and you must remember ADPKD is one of the situations where it may be a copy number variant also. So you may have to do a combo test. You may have to do both a whole exome sequence, targeted whole exome sequence, as well as an MLPA to get a diagnosis. So there are certain where you must do both in order to get a proper diagnosis.
So you were talking about ADPKD just now. So in cystic kidney disease, including polycystic kidney disease, what is your approach to genetic testing? Why would you want to do it? Now, for example, in a clinical case scenario, I find a patient, 45 years old, he has plenty of cysts in both kidneys, enlarged kidneys. I look at the Mayo Clinic classification, I'll decide about tolvaptan. I'll tell him this is genetic. Go and tell your family members to come and screen themselves and so on. 45 years old, I already know that I've made a diagnosis of polycystic kidney disease. Is there any sense of doing a genetic test in this patient? Apart from this, in cystic kidney diseases as such, which is a different kettle of fish, and there's a wide variation there. But why would you want to do a genetic test in this polycystic kidney disease patient that I've already clinically diagnosed?
So that's a very good question, actually, because when the disease is very obvious, there is no need for a genetic study for us to tell us that this is ADPKD. And you know the exact genetic mutation, that's the only thing. But there are one or two things, situations where it makes a difference. One is if the patient is going for a transplant and you have a relative who is going to donate, who's a younger person, say a son or something like that, and we are not really convinced about the phenotype in the son, then you have to do a genetic test. In that case, you have to first do a genetic test in this patient.
Right.
And the advantage of that is that you know the precise mutation which is there in this patient. So you can do the genetic study of son for that particular mutation alone, that particular variant alone. And therefore, what you get is that that is much cheaper and faster also. So you can make a diagnosis. The second thing is, if suppose the patient has no family history, then you don't know what type of disease it is, how it will progress, whether you want to give tolvaptan, that's actually an ADPKD without a family history. It may be some other cystic disease, like there are other cystic diseases, autosomal dominant tubulointerstitial disease, which can present with cysts. So that is where you would like to do a genetic study. The third reason is that if there is a truncating mutation, that is portends a very bad prognosis. So it is in fact one of the pro-PKD classification criteria. They take a genetic study also into it in order to make a that prognostic evaluation. So these are reasons why you would like to do a genetic study in ADPKD. But then, of course, like I said, it costs money, and it isn't. This money is not usually covered by insurance and others. So that will be a time when you would want to take a call on whether you actually want to do it or not.
Fair enough. What about CKDU as a different set where you have these belts in Andhra and other places where you have CKDU on the rise? Have there been any genetic studies done there, and would you advise genetic tests in this situation?
I think there are the genetic studies done in hotspots of CKDU, and the yield has not been great because most of them have not been genetic diseases, but some genetic diseases have cropped up. But that maybe, the amount of this cropped up will be the same as in any garden variety CKD that you are going to see. So it's not particularly a genetic disease. Most of it is related to either heat stress or chemicals or occupation and other things. So the genetic background is not there. On the other hand, you look at it from other viewpoint, you have an undiagnosed CKD who is going for a transplant. There you would like to know a genetic background in order to see whether it's a genetic disease or not. So there may be reasons to do a genetic study, not to make not exactly for CKDU, but to make a proper genetic diagnosis in patients who may or may not have CKDU.
Fair enough. So we'll move from these monogenic disorders such as PKD to the risk alleles such as APOL1. What do you have to say? See, from my knowledge of APOL1, this is mainly related to Black African, descent and so on. We don't see APOL1 in the Indian context. That's what I understand. Obviously, there is some connection with trypanosomal antigen and so on, the APOL1, the protection against sleeping sickness. But APOL1, I understand that it's a risk allele, but is it important in the Indian context?
No, I don't think from the Indian context anybody has reported APOL1 risk alleles. The interesting thing about APOL1 is the factor, how it makes a difference, because APOL1 as such doesn't cause renal disease, but APOL1 predisposes renal disease. Right. So here what happens is that because you have a risk phenotype in APOL1, G1, G2, G1, G1, G2, G2, and etc. Those are all the common phenotypes which can cause disease. And what happens if you have a risk allele, that doesn't mean you're going to develop a disease, but it has an increased risk for certain things, like you have a environmental influence which is causing, say you have a nephrectomy you donate a kidney to somebody else, that kidney is going to develop fistula in future because there is already some problem in the kidney. So these are all the risk factors that we have taken into account. The importance is that it's not like a traditional monogenic disorder. You have the gene, say you have a COL4A4 A5 mutation, you're going to develop Alport syndrome. But here it's not like that. You have a APOL1 doesn't mean you're going to develop renal disease, but there is a higher probability for it to develop renal disease than others. So one of the corollaries we have in India is our susceptibility genes for complement mediated disorders. Say you have a CFH mutation, that doesn't always cause disease. So patients with CFH mutation develop disease, say following some definite event like a pregnancy or a major surgery. And after that, they may continue to have the same problem later. Some of them may get resolved and they may not have anything. So if you look at the eculizumab trials also, there are certain people who are able to stop eculizumab after a period of time. Some people whom they are not able to stop eculizumab. So then there are similar type of mutations also of variants. So the genetic variant is actually here also something like a risk allele. It's a susceptibility allele. It doesn't invariably mean that you will get the disease. And there may be family members with the similar variants who may not have disease. So it may be one reason why you don't want to unnecessarily screen all the family members for disease, because unnecessarily you will be labeling them as having an allele where they may not have. So these are all problems with genetic testing which we have, and I really don't know how you're going to resolve that, but these are the problems, because the risk alleles are a problem. It's a different matter from monogenic disorders, and your prognostication, everything will depend upon the type of risk allele, and not only upon that, and how the disease behaves over time.
Fair enough. I was actually going to ask you about complement mediated disorders having complicated genetics, but you already touched upon that. Anything else you have to say in that sort of area?
Yes, complement is one of the things we are seeing nowadays. Is previously we used to say atypical HUS. Now we don't use the term anymore because the TMAs are being very well defined nowadays, the thrombotic microangiopathies. So here you have a complement mediated HUS that can be either due to a genetic disorder of complement, or it can be an antibody to complement, like anti-CFH antibody. And sometimes it can be due to C3 nephritic factors, which cause actually a C3GN type of disease rather than a AHUS type of disease. So what the diseases here are mainly in the complement regulatory factors as well as in the complement factors like C3, factor B, and then the regulatory factors CFH, CFI, etc. But there is a peculiar group of proteins known as the CFHR proteins, that is complement factor H related proteins. Now these are CFHR 1, 2, 3, 4, and 5. All of these are present in the body. Their exact role in the body is not really known. But what happens in general is that these CFHRs actually attach to the same receptors as CFH. So if they are acting more, then CFH will not be able to act, and CFH will not be able to regulate the protein cascade. So, but these proteins are all present in everyone, in all of us. And deletions and duplications in these are very common in the population. So if you look at heterozygous duplications in CFHR 1 and 3 and 4, these are very common in the population. About 30 to 40% of Indians and Pakistanis have this particular heterozygous variant. Now, some people, because this is so common, the people with the same heterozygous variant, two of them can get married and have a progeny with the homozygous variant. Now, the homozygous variant also develops complement disease, but only by means of producing an antibody against CFH. Now, why it predisposes to a CFH antibody is also not very clear, but they develop antibody CFH and they develop disease. So, in general, when you have CFHR variants, they don't really cause a disease except by means of an antibody. Whereas if you have a genetic variant in CFH which is pathogenic, then it will cause definitely by itself, by a genetic disorder itself, can cause a complement mediated hemolytic uremic syndrome. I hope I have been clear in what I have said.
Absolutely. Now, regarding genetic testing in the USA, patients are protected by the GINA, the Against Discrimination of Patients Who Develop Genetic Diseases, the GINA Act, wherein insurance companies cannot deny insurance to such patients with genetic disease. Is there any such thing happening in India? Is there anything at all? Because generally, is this congenital? Is this genetic? And our insurance companies will strike the patient off the list. What is your take on this in the Indian context?
So if you see that what most of the, when you fill up a form for insurance, they generally ask the question, is it congenital or is it genetic?
Right.
And you write no. But what has happened is that this was actually insurance companies are flatly refusing genetic and congenital disorders till 20 when the Supreme Court made a critical judgment of that, saying that you cannot just refuse blindly just because a patient is having a genetic disorder. That is discrimination. That is against the Indian Constitution. And then the IRDA came out with a regulation in 2020 saying that insurance companies cannot deny insurance benefits just because it is a genetic disorder. Now, that is the only statement which is made. Now, unfortunately, it is not been clarified in detail. So, which genetic disorder, how to deny. They have also said that you can charge increased premiums based on that.
I see.
So, the field is not very clear. All we know is that just because of genetic disorder, the insurance company cannot refuse. But beyond that, exactly what are the terms and conditions, what happens to the refuse, we are not really sure. So it's not very clear. They don't have a definite act like you have in the USA or in the Western. Most of the Western countries have definite rules in place to prevent this type of insurance-mediated problems.
Right. So that's a pretty interesting session we had just there about genetics in clinical nephrology. So, Dr. Satish Balan, what message would you pass on to the nephrologist, let's say in private practice or government practice, looking at his patient with certain disease situations? Where does he, your final message here, where does he need to do these genetic tests in his clinic?
Yes. So there are certain things which I would like to say. One is that when you're doing a genetic test, is not just like ordering another lab test. So there has to be mandatory genetic counseling. It is better that either you should get trained in genetic counseling or you should use a trained genetic counselor. Now, people working in a small setup, you may not be having access to a genetic counselor. So one of the things that we can do is that we can get a genetic counselor from the lab that you are going to do a genetic test. They will be willing to come and do a counseling. So you have to do a pre-test counseling, you have to do a post-test counseling, and make sure they understand the implications. So problem is that suppose you do a genetic test and you get a no result, then they'll come and say, you said it's a genetic disorder, there is no disorder, why did I spend my money on this, etc. And then you have a VUS, that is a variant of uncertain significance. That is one thing which we didn't discuss about VUS.
Correct.
So that is one problem, because on that basis you cannot make any recommendations as far as the progeny are concerned, the children are concerned, or the future of this. You cannot use that to make a proper prognostication or diagnosis, VUS. So these are all things which should be explained beforehand. And once the result is ready, again, counseling should be done. So counseling is an important part of the genetic test. Don't just do a genetic test without doing a proper counseling. So that, having said that, it is now becoming important. See, many of us ignore genetics completely. We'd say we don't know anything about genetics and we are not trained in genetics, etc. But then it is becoming more and more important to make a precise diagnosis. So you look at the KDIGO recent guidelines on CKD, they have made a very clear statement that you should take every measure in order to ensure that you have proper diagnosis in every patient. And that includes genetic testing. So you have to do a genetic testing where it's situation where you suspect a genetic disorder. I have told you already what are the major situations where you should suspect a genetic disorder, and you take the decision to do genetic tests. Use a genetic counselor to do that. If you can't do it, the labs will always be very happy to. It's not ideal to have a lab genetic counselor do the test because they have a vested interest in that, and there's a certain conflict of interest there. But still, it is better than nothing because the patient gets the counseling anyway. So we have a genetic counselor from one of the labs who was doing counseling, and she was doing a very good job, excellent counseling. And he does not do it just to make, so it says what are the implications, what are the things, and you can do genetics based on the counseling, etc. So you have to do a genetic test wherever necessary. You have to know a little bit of genetics. You have to know what all genetic tests are available now and how you should utilize them properly. If you don't know how to utilize them, you can always talk with somebody else who knows, and there are a lot of people here who are willing to explain to you. And don't forget genetic counseling. So these are things I would like to say.
Thank you, Dr. Satish Balan, for joining us and giving us valuable information on genetics in clinical nephrology on this Kidney Conversation podcast. This was the 11th episode of Kidney Conversations, a podcast brought to you by the Indian Society of Nephrology's social media team. This podcast is available on Amazon Music as well as Spotify. Do join us, do subscribe to us at ISN underscore India. You can follow us on Twitter on this ID, the same ID at ISN underscore India, on Instagram as well. There is an ISN India group on Facebook that you can join. There is a YouTube channel of the Indian Society of Nephrology, which is very much subscribed to these days because of the excellent clinics in nephrology that is being conducted. Another Indian Society of Nephrology initiative. Do join us. Do listen to this podcast on Spotify or Amazon Music. Thank you, Dr. Satish Balan, very much.
Thank you. It's been an honor.
Thank you.